we would like to. Oh, got it. Okay, so let's look at the definition. And for adults, in adults, it's defined as any weight that is higher than what is considered healthy for any given height. And it could be overweight, it could be obesity. Okay, and you're going to see why it could be overweight, it could be obesity. Now, let's look at what are the tools we use to screen out people who are obese. We don't use this screen to diagnose obesity or overweight. We just use it to screen, okay? So it's called body mass index. It's a screening tool used to determine weight categories in adults as well as children and teens, okay? So I'd like you to have that in mind, because this is a tool you could actually Google yourself and it comes up with the way to calculate it, which is the next thing we're talking about here, which is how do we calculate this weight? This is the patient's weight in kilograms, and you divide this by the square root of the height in meters, okay? You can actually do that later and see for yourself. It just actually pulls up with the actual formula, and then you can just put in the weight just like it says, and you get your BMI, okay? Now let's go to classifications and categories of weight using this BMI we just talked about. Now, BMI that is less than 18.5 means one falls within the underweight range. And this is kind of significant because there's some people or patients who actually fall into this category, and you have to keep an eye. It's a red flag, actually, when it comes to mental health. So I'm not going into that today. So the other classification will be BMI of 18.5 to less than 25. That's where a lot of people want to be at, because it means one falls within the healthy range. Okay, once you creep into BMI of 25 to less than 30, it means one falls within the overweight range, okay? And then you have the BMI of 30 and greater than or more, it means one falls within the obesity range, and that is kind of red flag, okay? So we shall go on to the next slide, which is why are we so focused on this topic in healthcare? Let me see how I can get this out of the way so you can see it. So, well, basically, it's based on prevalence, socioeconomic status, and worldwide issues. So let's start with prevalence. I mentioned that for the kids here because a lot of patients would give you a history of obesity in childhood. So I kind of decided to put in here that children and teens in the US, for example, 1 in 5 are affected by this condition, and they actually grow into obesity, okay? It's also common and serious and expensive disease condition in adults as well. So it's costing any government a lot of money to manage, because most of these patients have got comorbidities attached to it as a result of this condition, okay? You also have other conditions like cancer, which is related to obesity, unfortunately. Such cancers as the gastrointestinal cancers, which in layman's language, we're talking about cancers that dwell in the stomach, in the intestines, colon, and all that, okay? Also associated with liver disease, liver cancers, kidney cancers, cervical, ovarian, and postmenopausal breast cancers. You have women that develop breast cancers later in the decades, like 79. My mother had cancer at 79, breast cancer at 79. So that's an example. And now let's look at the obesity categories. The reason why I put it here is because I wanted you to focus on classification of obesity, because it's related to how we treat or how we manage obesity. So let's go. We have class 1, 2, and 3. So when you have a BMI of 30 to less than 35, that will be class 1. When we have a BMI of class 2, so we have a BMI of 35 to less than 40, we're looking at class 2. And then when we have a BMI of 40 or more, this is class 3. And we consider it as severe obesity. And sometimes people, some of my colleagues tend to want to start medication in this kind of patients. Okay, now let's look at the factors that would contribute to weight gain. And would look at different factors, which are all very important. Now, the simple things are like poor life patterns. What are poor life patterns? We're looking at sleep, your sleep pattern, how is it? Physical activity, are you sedentary? You know, and then eating habits, how do you eat? How do you chew your food and all that? These things are factored in treatment or management of obesity in patients nowadays. And you're going to see why in the next slides. Now, we also have genetics. Some people, you find they have family history. Dad is obese. The sons get to a particular age, they're obese, and they don't eat as much as other people. But the typical thing we see in them is they get hungry increasingly, frequently, and they eat as well. But sometimes they don't even eat big amounts of food, but they just get hungry and they eat. Okay, and then you also have certain illnesses related to obesity. There are quite a number, but I mentioned Cushing's here because it's quite, it's normally overlooked. And you also have those related to medications. Examples I have given here are like steroids and antidepressants, which are very common. There's other conditions, other medications that would cause obesity. So when a patient comes to me, one of the very, very vital things to do is to look into the drug history to see what they're taking. Then you have other factors such as stress, very common nowadays, and pregnancy. Then we also have the social determinants of health, which is SDOH in short. And these are conditions in which one lives, so, or learns or works in, okay? For example, I worked in the hospital and they served anything, and that is all you can eat. And those things might not be healthy enough. And that is where, if you dwelled on foods from the canteen or cafeteria, then you find that you start to put on weight because you're not eating, you're literally eating processed foods. The same thing in schools. So that's why, that's what the social determinants of health is referring to. Okay, so you just base your eating around what is available to you in schools, offices, and hospitals, even patients. Now, how does the provider tackle this problem? How do we tackle this problem? Everybody tackles this problem in different ways. I personally have a way of getting through first. The first thing I'm going to do if I had a patient is I want to fully assess the patient, and that could take about 45 minutes because I must take a good history and kind of screen out the evident triggers, review the patient's prescription, get everything I need that's just going to give me a picture. Okay, so that's the full assessment we're talking about. And then we also look at the patient's life pattern, which is also part of the history too, because you have to find out how are you eating, the eating patterns, physical activity, sleep patterns, all this, just like we mentioned prior. And then we want to find out about also where they're working, what do they do. If you're somebody that goes to the office, for example, do you take your food to work? Do you eat out every time you go to work? That kind of thing. So we have to look at all that. And then we now, there's a lot of collaboration in the society between providers and companies, but it's kind of almost fruitless because a lot of companies are making money from the foods that they provide for an institution. For example, canteen in a workplace is provided by some company, and there's an amount of salt and sugar in those foods, probably to preserve it. And it's kind of a catch-22, trying to work with them to take off those things that will make the food healthy. So that's a big barrier in that issue. So I don't know when that is going to be sorted out, but I suppose the patient will have to have a way of going around eating out, eating at the workplace and all that, or eating in school and stuff like that, especially if you have this problem with obesity. Now let's look at how do we manage these patients. Everybody, I think every physician has a way of doing this stuff. But I personally, before I start, could we just ignore class 4? It's just class 3, it's just a typo. So after this presentation, I'm going to be, fixing that so that I can share it if you needed to share it. Now let's look at it. So we kind of start with, there's some people who are obese who are unable to mobilize. They've slowed down, and you want to wonder, how am I going to make this patient lose weight? Because they're not going to exercise. I'm not going to encourage the patient to exercise with a weight-bearing joints, which could actually get damaged, so damaged that when they come off the weight, they are not even able to use their limbs properly because the joints are already osteoarthritic, okay? So I tend to start with what they call the very low calorie diet, which is simple, it's just a term, but it means that whatever shake they're drinking would be about 800 calories per day. So maybe it's about 200 a shake, or 200, so times 4 or times 5, depending on the weight. If the patient says, oh, I get hungry, you don't want your patient to go grabbing other things. So you might as well give them more of this. So 800 calories a day is kind of an estimation of what could be offered, and it has to be monitored by a provider for about 12 weeks. It could be less because some people start to burn fat very fast, okay? And then in this program, when we see the patient is losing the weight, we start to reprogram. What is this reprogramming thing we're talking about? It dwells on the life pattern, the patterns of, we talked about earlier, the sleep pattern, the eating pattern and all that. This is what is encompassed in the 90-day program. So and this takes a large chunk of the consultation because it's kind of a way of changing a patient's habit. And this is very important because if you've taken time to lose the weight, drinking shakes for 12 weeks and you were successful, you might as well just do something so that you never come back to being obese again. And that's what the 90-day program is dealing with. And it's very, very successful, okay? So for the class 1 and 2, we don't really encourage this VLCD, but it could be personalized, to be honest, because it depends on the patient and the history I have gotten from the patient. I might decide to say, okay, I'm going to create a plan. How about introducing you with 2 shakes a day and a meal, and then we taper it down. It all depends on what is in front of me. You might not have to be on it, you might be on it, but it's dependent on the patient's needs. And so in this class, we tend to create a food plan, which is successful, which is based on the foods you eat, because everything about obesity is about knowing everything about what gets into your mouth and then restructuring it so that it suits you and you can go along with it without defaulting, okay? And then this also, you also have to be part of the 90-day program here, because just like I said, the 90-day program is just to deal with changing your habits and changing it for good. And you actually do it yourself, because the sequence of questions I ask you is what is going to lead you to knowing that you actually know what to do, but you're just not doing it. Okay, so that's what we do for class 1, 2, and 3. Okay, we've talked about. Now, there's other ways of treating. Some people could be resistant to everything, especially those in class 3. So sometimes we could introduce, I would introduce medications. And there's a new medication that came up this summer that is, I think I'm very interested in it because some of the people who are obese have type 2 diabetes, and this actually tackles your diabetes as well. So it's like killing 2 birds with 1 stone. So in last case scenario, if a patient comes to me and has a lot of chronic conditions such as diabetes, which is one very important situation that I take seriously, then I might, couple it with a prescription. But before I do that, I like to try them on normal stuff to see how far they can go. But if a patient's diabetes, for example, is going through the roof, uncontrollable, I know that when the weight goes down, that could actually improve. Okay, so you have other treatments as well, like devices, intraluminal devices, and also you have surgery, bariatric surgery, which has a good success rate, to be honest. I haven't done one because I'm not a surgeon, but from what I read, that's exactly what they're saying. So to close today, I would say that studies demonstrate that physical activity and a lower BMI is associated with less risk for obesity-related cancers, like we mentioned, those cancers. And then 5 to 10% of weight loss improves obesity-related comorbidities, like the type 2 diabetes mellitus we just talked about, cardiovascular mortalities, lipid profiles. When we say lipid profiles, we mean we're referring to things like high cholesterol, high hyperlipidemia, then hypertension. Some people have hypertension creeping up in the later part of their lives, related to obesity, osteoarthritis, like we mentioned, obstructive sleep apnea, OSA, which happens a lot with people who are obese. This kind of choking in their sleep, and they have to use the machine at night. And then, of course, the quality of life is also improved. So your quality of life would always improve with reduction in weight. Trust me. Yes. So that's the end of my presentation, and I'll thank you for listening to my presentation, and I would honor any questions at the moment.
Thanks so much, Dr. Edith. Does anyone have any questions for us? Hi, Douglas, please go ahead. What's your question? Do you want to type it in the chat, please?
Oh, you want to speak? Okay.
Or I can unmute you.
Yeah. Oh, somebody, Douglas, Dennis has raised his hand up. What's the best treatment for obesity? What's the best treatment? Well, can I lose weight on? Okay, let me see. Let's tackle the first one. He said, what's the best treatment for obesity? I don't know that there's a best treatment for, you have to start from the simple things, just like we mentioned. It's basically looking at what you're eating and trying to reduce your weight, depending on where you are, based on the classification we just talked about, based on the class 1, 2, and 3, where do you fall into, based on your BMI, because if you have a very high BMI, we have to start to do something about the weight. So I wouldn't say there's something that you're going to do to treat it, because I believe that if you eat okay, some people don't need medication at all. I've seen people who are very obese and they just did what they're supposed to do and the weight just dropped. But my interest in the 90-day program is, it will change your habit for good, because it will stop you from what they call this yo-yo diets, where people lose weight, they look good for the next 1 year to 2 years, and then you see the weight coming because they've taken off their guards. But the 90-day program stops you from taking off your guard, because you're now eating well and doing the right things. Okay, so I wouldn't say that there is a treatment, but there's medications they can offer you to see whether it even helps you to do that. Okay, some people decide to get frustrated with even going through medication and decide they want to go for the devices we talked about, or even surgery. Okay, I've seen people who have put the intraluminal ring, and they just could not carry on with that. And, you know, they just almost, because the ring stops them from increasing the amount of food that goes into them, but they still get hungry. So that's why I think it's best to do the normal thing, which is change your habits and eat right at the end of the day, because that way it's easier. You can eat what you like, but the way you eat it is different, because all these things factor into your parasympathetic system activation or deactivation, and also your sympathetics is all connected to the brain. Okay, so that's what the 90-day program is all about, because by the time you go through it, which is about 90 days, you should be on your path to never putting on weight again. So now the next question is, can I lose weight on, let me ask Dennis Douglas, did I answer your question, or you have something else to add, to ask me for clarification? Okay, great. Okay, now Miriam, you asked, can I lose weight on only one part of my body? Can I lose weight on only one part of my body? What do you mean by that? You said, can I lose weight on only one part of my body?
I think probably what she's saying, for example,
you mean like somebody who has a stroke?
Some people like to have certain parts of their body.
Certain what?
Very voluptuous. They would wear different cultures. So you can lose it in the whole body.
Sorry, I didn't even get you. You're breaking up. You said, can I lose weight?
My connection's not very good.
Can I lose weight on only one part of my body?
She said, for example,
okay, let me just answer Franklin.
For example, only on her stomach.
Oh, I see what you mean. Well, the thing is, when you start to lose weight, for people who have weight around their stomach, which is very common, okay, and those ones that have weight around their stomachs those are related to a lot of disease conditions, right? Now, when you start losing weight, maybe it's nature, but it starts to go off your stomach area, your hip area, your thigh area, okay? And if you're somebody that loses weight from head to toe, you could even notice on your face and your neck. But the places that you'd notice a change will be your stomach, okay? And then it goes down to your thighs and your hip. So yes, you can lose weight the way God created the body. When you start from somewhere, then the other places take over. You start noticing on your arms, your arms and your chest, like that. But the first places that are tackled with weight loss is stomach, your hip area, your thighs, okay? And then it starts to go out, and then your anatomy starts to come back, because that's just what nature is all about. Your shoulders get narrower, your chests get smaller, so that's just what it is. So yes, you can lose weight on, it starts, I won't say you can only lose on one part of your body. You can't lose on the stomach and then it goes away. No, fat, anywhere there's fat is where it goes to, and it tackles it. And yes, you have to, the way God created the body, anywhere there's fat, if you're losing weight, that fat goes away, because the fat is not supposed to be there in the first place. Did I answer your question, Miriam? Okay, great. Okay, so now Franklin asks a question. He said, for a family with history of obesity, can physical activity reduce their chances of getting obese? I don't think so. That's the monogenic obesity I talked about. You notice that a lot of people go to the gym and think that's the answer. No, they get frustrated, unfortunately. So for people who have a family, those are the people I'm actually very interested in. I remember in the beginning of my presentation, I did say I had interest in clinical research, which is what brought me to America. So, and obesity is somewhere that I'm very keen on, because in my family, I got one branch of my family, their dad was obese, and the sons and daughters are all obese. When they get to the age of 20, it starts to, they start to put on weight, and they actually are big. So I think those types need medication to try, along with what we talked about food, as a trial. But I'm still looking out to pharmaceutical companies who will be interested in my thoughts about this type of obesity, because it's quite common. I've seen a lot of it, and they actually lose weight with this very VLCD. But I think to put the weight away, there has to be some medication that is going to, taper it down. What I don't know is how long are they going to do it? For the medication I shared with you guys, if that patient had diabetes, for example, then that patient can be on that because it's helping their diabetes. Okay, but if you tell me that the diet thing can help, yes, it can help. But a lot of these people, I think, are the ones that actually go for the bariatric surgery. People who have tried all kinds of things. And when you look in their family, they actually have family members, siblings that are obese. And they're the ones I think tend to go for the bariatric surgery and are off the weight, because, they need their quality of life in check. Okay. So did I answer your question? I would think for physical activity, it's just going to be maintenance for them, because you can't be jumping on the treadmill with your knees are going to go away. So I would think the first thing is to tackle the obesity, and physical activity cannot be the thing to help them, because it will not work. It won't. But if they key in all these things we talked about, start with diets, take care of the way they eat, do everything they're supposed to do, go through medication, and it doesn't work, then the next thing will be the bariatric surgery. And before you do bariatric surgery, you have to be a particular weight for them to do the surgery for you. So that's just how it works. So that's why the diet thing is important. Come down to a particular weight before you do the surgery. And then they'll take it from there. Then they can maintain it with whatever physical activity of choice. But for me, I normally don't encourage anybody to pump, jump around on their knees, because your knees, your joints, your knee joints and ankle joints are not meant, when we were created, the weight you have is not for those joints. So you're literally damaging them. So I think weight resistant exercises are kind of the things I encourage, things where you push a lot of weight, I don't know what they call them, is but I know what I'm talking about. You use dumbbells, you use your legs, you push against weight and all that. So that's kind of exercise. But anything that is going to make you jump like a treadmill is not something that I encourage. So I hope I answered your question, Mr. Franklin. Okay, thank you.
Yeah.
Okay, yeah.
Thank you so much, Dr. Edith. I think we've got the questions. Dr. Edith has been kind enough to offer the first 3 people who sign up to any of our care plans some free consultations. So if anyone wants some more insights, some more specifics, you can go ahead and book a consultation with Dr. Edith through the DiagnoStar platform. Basically, just go to diagnostar.com, look at our different plans and sign up for one. And once you're signed up, you can go ahead and make an appointment with Dr. Edith. And as I mentioned, the first 3 people who sign up will get a free consultation, compliments of Dr. Edith. And I think in that she'll be able to go into more of your specifics and answer for your own, body type and your weight loss goals, what would be the best solutions. So she can help you out with that. And also, before we go, make sure you follow us on our different social medias, like Instagram at DiagnoStar Healthcare, Facebook and LinkedIn. And if you have any other additional questions, you can feel free to reach out to us. You have our email from signing up for the webinar, and we're happy to give you any more additional help and look forward to helping you out with healthcare through diagnostar.com. Thank you, Dr. Edith. We really appreciate your time today. And I appreciate everybody for signing up for the webinar. And hopefully it was helpful and useful. And we look forward to helping you with your healthcare in the future.
Thank you.
Thank you. Bye.
Bye.